Hello, good morning, good afternoon, good evening, depending on where you're joining us from in the world. Welcome to our weekly platform, the Africa CDC weekly press briefing, catering for updates on health emergency on the continent. As you know, the platform is set to facilitate our weekly engagement with members of the media and the public at large through this medium, and we're here to provide you the latest update, focusing this week on the ongoing Marburg virus disease outbreak in Ethiopia, and of course, the multi-country Mpox, and as well as cholera in parts of the continent. As usual, we are joined by senior technical experts from the emergency preparedness and response team, the Continental Incident Management Support Team that's seated in the Democratic Republic of the Congo. Today we have with us Professor Yap Bom II. He's the Deputy Head of the Incident Management Support Team, the IMST in DRC. He'll be providing us the updates and some new information that has come since we last met last week. My name is Nike Wongwe. I'll be moderating the section for today. And just to remind you as we commence the section that we have availability for language choice, that is French to English and English to French. You can go to the Zoom icon, the area for language, and select your preferred language, which will be French, since we're speaking on the main channel in English, and you can follow the section through that means. Prof, I'll turn over to you for the introduction as we move on with the session for today. Over to you.
Thank you so much, Nick. Good morning, good afternoon, good evening, depending on where you are. I'm pleased to take the briefing today on behalf of our Director General, Excellency Dr. John Kaseya, who at the same time is signing an MOU with Zipline to ensure that we actually strengthen the new vision of Africa CDC on the Africa health, security, and sovereignty. This is a key component. And on Monday, we'll be signing another MOU, this time with Starlink, because one of the key pillars on that new vision is the digitalization. And there is no digitalization if there is no connectivity. And today I'm taking the briefing from Rabat, where the APORA, the African Partner Outbreak Response Alliance, these are military force who are put as the theme of their meeting this time to bridging force for health security, operationalizing civil-military collaboration in outbreak preparedness and response. You recall all the time where we've been challenged on how to respond to outbreaks, Mpox, cholera in eastern part of DRC, in South Sudan and so on. So this is the opportunity to bring together the military so that we have a comprehensive and holistic way of responding to outbreaks. So I'm pleased to take the briefing today, and then Nick, I think we can move forward with the presentation. Thank you, Nick. So this week has been quite an engaging week on the many fora. The first one was really to continue the dissemination of the new vision of Africa CDC that has already mentioned the health, security, and sovereignty. And this time was in Burundi, where our Director General has been engaging at the highest level, the President of Burundi. Really first to commend the country for the Mpox response. Remember that Burundi is one of the countries that has been able to significantly reduce the burden of Mpox without using vaccine, but emphasizing the decentralization of the laboratory, the isolation of patients, quite a number of strong activity that was worked commending. So it was also an opportunity to reaffirm the commitment to support Burundi, to assume the leadership that they will have at the highest level of the African Union, as they will be the next chair starting from next year. It was also the opportunity to reemphasize that the response to outbreaks rely out of the Ministry of Health. That's why the Minister of Finance has also been engaged on those discussions. Next slide. On the fight and resource mobilization against cholera and Mpox, it was critical to engage the different partners, WHO, UNICEF, and others, which are part of the IMST, to appreciate the effort that we've been able to implement together as one team behind one plan, one budget, and one M&E. And on the other side, also to support the effort that the First Lady is putting in place to mobilize resources for the fight against cholera. We've all agree, and then we'll see later in the presentation how critical it is to have the public-private partnership so that they can work on increasing the infrastructure to ensure that population have access to clean water. This is an achievement that Burundi is putting in place, bringing all those together. Next slide. Prior to that, there was the high level of universal health coverage with global health leaders, which happened in Tokyo, led by the World Bank and the World Health Organization. It was really to see and explore how can accelerate the progress toward health for all in an environment where the ODA has decreased, where we need to do better with less. So the Africa CDC Director General, Dr. Kaseya, shared how AU member states are boosting domestic health financing, but also investing in what is most critical as we are talking about universal healthcare, which is the primary healthcare to build resilient system, but also to design and agree the key step toward health sovereignty. It was also an opportunity at this time where the constraint, where all the challenges are facing, especially in terms of financial challenges, to comment and to thank the government of Japan and the World Health Organization, the World Bank, for convening this very important dialogue. Next slide. Now, going back to our public health event, as we are moving toward the end of the year, it's one of the most critical time period of the year for many reasons. The first one is that it will be the time where people will gather, where the diaspora will come back, where people will be in the festive season, and where some of those diseases will have the opportunity to spread. So it's critical to highlight that as we are going toward it, we still have Mpox, as you will see, though we see the case reducing, still transmission going on in many countries. We have cholera, which is still affecting 25 member states with more than 300,000 suspected cases. And we know that in some countries, it will also be the time of the rainy season. Measles is also continue to carry in 20 member states. Dengue, Lassa fever are also still reporting some case and also some death. As we'll see for Lassa fever, we've reported so far 192 deaths. Next slide. In Ethiopia, altogether, 1,676 samples has been tested, 13 confirmed cases, 8 deaths, making a case fatality rate of 62%. And we still have those two zones that have been affected, which is the Arizona Jinka town and Awasa city. So what has been important to highlight this week is the increase in testing capacity. So as you can see, we moved from 431 sample that has been tested to 940 with only one confirmed case that has been highlighted. So on the side of the cross-border collaboration and coordination, we have South Sudan, Somalia, who have completed, as mentioned earlier, the readiness assessment. And next week, on Tuesday, we'll have a meeting with South Sudan, Somalia, and Kenya to monitor and see how far they are on the preparedness, and then see where are the gaps so that they can receive the adequate support from the IMST and the different partners. As far as Ethiopia is concerned, in terms of treatment, they are using the monoclonal antibody to strengthen the capacity to manage Marburg in patients quickly and effectively, but also have including the vaccination with 2,500 doses of the investigational child Marburg vaccine to target the population as part of the Marburg virus response. Next slide. As you see now, Mpox, the confirmed cases are going down, reducing by 11%, 159 to 142. And what is important to highlight is that we've reached the 205% case that we've seen in 2025 as compared to 2024. So the cases have definitely doubled. However, the good news is that we continue to see that reduction in the number of cases in most of the affected member states. Over the last 6 weeks, we have DRC, Liberia, Ghana, Kenya, Burundi, Guinea, Uganda, and Nigeria that together contribute for 92% of the case. As you will see in the presentation, those are also the country where the colleagues are currently in the field supporting in terms of surveillance, vaccination, case management to ensure that, as mentioned, as much as we can before Christmas, we can really see the curve bending in some of those hotspot country. The other good news is that when we look at when we were in the peak 6 weeks ago, we have an 84% decline at the continental level. Next slide. So saying that, you can see that most of the country has going down in terms of transmission. We have some few countries like Burundi where there is a stabilization, but we are moving from 96, from 70 case, confirmed case 6 weeks ago to 96. We have Nigeria, which is also stable, 41 and 44. So basically, either we are stable or we are going down. The majority of high-burden countries are decreasing: DRC, Sierra Leone, Uganda, Kenya, Liberia, and Ghana, which is quite encouraging. And then we have the two countries, Namibia and Rwanda, that remain stable, very, very low level. We know that since then, Namibia has only reported 2 cases, which has been out now. And then Rwanda, from the 47 cases that they had in 2025, they've not reported any new case of late. Next slide. In Mali, where we also have our colleague from IMST going to support, they've been reporting so far 6 confirmed cases out of 27 suspected cases. 0 death has been confirmed. There are 2 districts that has been affected, as you can see in the map. So in the country, so far, the testing coverage is pretty high, 100%. The testing rate as well. The test positivity is 100% because that with only two patients, those are the one that they've managed to get. So 27 cases for 2 confirmed cases. This is an average of 12 contact for the case, which is not 20, but which is already also a good number. Next slide. In Burundi, as mentioned, we are still seeing the downward trend, though they have with 2 confirmed case only that has been reported this week. The clade 1B is still the one, and those few cases are still happening only in Bujumbura City Hall, which has been so far cumulatively reporting more than 60% of the case. So now, since the 1st of September, 180 confirmed cases has been reported, 92% from Bujumbura City that has already mentioned, but also from the Bujumbura South. So these are really the 2 districts where the efforts are being emphasized, as you will see also trying to respond to Mpox, but an integration manner to cholera as well. Next slide. Liberia has been the country with quite a number of attention because this is really the one where we are seeing the upward trend, and we are glad to see that for the last 3 weeks we've been seeing some reduction, though this week it was a small increase from 17 to 24. All the 15 counties have been affected so far. with 6 deaths out of 1,429, making a case fatality ratio of 0.4. So what is important to highlight is, yes, most of the case, 7 out of 10 are on the side of Montserrado. This is also the place where all the effort on vaccination, surveillance are currently in place. We have a team of some of them are connected to this press briefing, currently working hand in hand with the Minister of Health, targeting one key point. As you can see in this presentation, you see the test positivity rate is around 89%, meaning that most of the positive are actually those who we see at the health facility, while we also know that most of the confirmed cases are still isolated at home. So the real support that this mission is bringing is to ensure that the active surveillance is put in place, and where there are gaps in terms of isolation patient in the health facility, they will also find the right solution and support in the country. Moreover, there will be some 20,000 doses of vaccine that are to be arrived soon, and that will also be an added value to support the response in Liberia. So hopefully, if all those measures are put in place, we believe that we'll continue to see the decline of the case as we go toward the Christmas season. Next slide. Kenya as well, for the last 6 weeks, we've been seeing some reduction in the number of cases, though this week we can see a bit of increase. Most likely, as you can see, the test positivity rate went down to 35%, meaning that the active surveillance in the community has been strengthened. And when we go in the community, that's also where we managed to find the case. We still have Mombasa, Busia, and Nairobi that together account for 67% of the total number of cases. So, as talking about Liberia, they will also be receiving, or they have received yesterday or 2 days ago, 20,000 doses of vaccine that will be used in the integrated manner with the surveillance to ensure that we really touch those are the most at risk of transmitting the disease, but also the most vulnerable. People living with HIV are one of the examples. So again, once again, the IMST is currently supporting the Kenya in the field, but looking on one side at Mpox, in the other side at cholera, as I will be showing later on. Next slide. Now, coming down to the vaccination, we are really touching the 5 million dose that has been delivered to 16 countries. So here you can see 488,000 that has been delivered. And since then, with the dose that are about to arrive, we should be able to reach the 4,900,000. So almost 2 million of people have been vaccinated so far with at least one dose. As mentioned, Kenya has received 20,000 doses on Tuesday, and then Liberia will receive on this Saturday 20,000 doses as well. We know and appreciate that vaccine is not the silver bullet, but definitely having the vaccine, as we've been seeing in Sierra Leone, as we've been seeing in Uganda and others, applying a targeted vaccination is definitely a game changer in some of those countries in stopping the disease, but more important also on preventing the severe form, especially in people living with HIV. Next slide. Now, specifically looking at Ghana, where the team was like last week supporting the vaccination campaign, once again, very, very targeted. You can see there were some few districts that were the one that has been focused for the vaccination. And also in terms of the profile of the people vaccinated, you will easily see that there were a target with the adult population, but also those that were most at risk or the most vulnerable. Next slide. All those results and more have been presented to the Emergency Consultative Group, the ECG, that took place yesterday. So this group of 14 scientists, experts, public health experts has really assessed all those data, asking quite a number of questions on one, appreciating the significant decrease, more than 90% of decrease in number of cases and number of deaths, but also asking question on the sustainability, on the transition roadmap that has been issued between the IMST and the member state. And based on all those information and using the criteria that they have, they will decide by the end of this week whether Mpox should be maintained or lifted as a public health emergency of continental security. So as soon as the information will be communicated, we'll communicate to you, the journalists, but definitely next week during the next press briefing, you will have the outcome of these consultative groups. Next slide. Now, moving to cholera, once again, for the last 6 weeks, Central Africa has been the one leading the outbreak in the continent, though before it was Eastern Africa. Central Africa is also the place where we have the highest case fatality ratio, as you can see, 3% as compared to 2 in the other part of the continent. As you can see, once again, we have 3 times more number of cases, and same thing for the number of deaths as we had 3 years ago in 2022, if needed, highlighting how critical it is to have that comprehensive collaboration, coordination to fight against cholera in the continent. Next slide. Now, when we look at the dynamic, you can see for all the country, they are either stable or decreasing. So the sharp decline are mainly seen in South Sudan, Sudan, Kenya, Ethiopia, and Burundi, while we see some moderate decline in Chad and Mozambique. So we have countries that are stable, talking about Somalia, DRC, but still, the high burden context, South Sudan, Sudan, and DRC are the country, three top country in terms of number of cases and number of deaths. Next slide. Yes, in Burundi, where our Director General was this week, you can see the decrease in the number of cases and the number of deaths, which is the result of the response, the multi-sectorial approach that has been put in place with the resource mobilization led by the First Lady, ensuring that the private sector is also brought on board to make accessible clean water by the implementation of borehole in some places where access to clean water was not available. But still, more needs to be done, and we believe that the resource mobilization effort will bring Burundi toward that. Since yesterday, again, we have a team of IMST on the field together with the Ministry of Health to see how all those efforts can be catalyzed so that they can really address the driver that we've been seeing, the poor access to safe water, which remain the key driver. And having in mind that, yes, the different effort on surveillance, case management are critical. As you can see, the case fatality ratio in Burundi is pretty low, but that might not be the most sustainable. The most sustainable ways of responding to cholera is definitely the WASH, as we will be seeing in the next country. Next slide. Moving to Angola, which definitely is a critical case study for us, highlighting how we move from the first wave to the second wave, while significant amount of vaccine has been used during that time for the first phase, showing the decline. Now in the second wave as well, a lot of effort has been put in place in terms of vaccination, in terms of WASH, but this is highlighting that more than that, what is needed are a different approach. While we've been pushing for reactive vaccination campaign, this might be the time to pause and to change our advocacy to the preventive vaccination in all spots. What does it mean? It means that instead of providing one dose of vaccine during the outbreak, we should really focus on those endemic countries and endemic region where they will have the proper 2 doses of vaccine so that it can give time to people to be immunized, because the duration is between 4 to 5 years on one side. On the other side, the multi-sectorial approach will ensure that during that time of peace, let's put it that way, we strengthen the availability of access to clean water. Because once again, it's important to remember that in Angola, in some places, they can reach up to 40% of that population that don't have access to clean waters. So this is a clear example of the need, the critical need for that multisectorial approach. And the colleagues of IMSC that are currently in Angola, starting from today or tomorrow, will actually strengthen that message toward the multisectorial approach. Next slide. In Kenya, a critical thing that need to be done differently to ensure that this reduction is sustainable. Next slide. Democratic Republic of Congo, definitely one of the most complex. We've been seeing that the DRC has been contributing to the highest number of cases and death as Mpox is concerned. Now it's one of the major country again as cholera is concerned. So far, 20 out of 26 province has been affected with a case fatality rate of 3%. The challenge remain the same, the size of the countries and the weak wash infrastructure to be implemented in the different part of the country. Now, the conflict displacement, especially in the eastern part of the country, this conflict has overcrowded the camps with poor sanitation. And now, as we are in December, the seasonal flooding and heavy rain also contaminated the water source. So this is also another case study on how we should rethink the way we are responding to those outbreaks. And that's why mentioning I'm currently in Rabat to see with the Apora how we can also provide some response in those environment, Eastern DRC, where the security is an issue. I think it's something critical. It's also going toward the multi-sectorial approach that we are looking forward. In DSS still, there are some resource mobilization efforts that are being put in place around the project Fleuve Congo Sans Choléra, and also they are working together with the colleagues of IMST. Next slide. So specifically in DSC, you can see the different area where we have the highest number of cases of death. You have the Olomami, and once again, you have the North and South Kivu, the eastern part of DSC. This is the part also where the access is quite complex. So on one side, we need peace, and we hope that the agreement that was signed recently will support on that. But in the meantime, we need to be able to access those populations using different tools, using these different partners to ensure that the population also receive the support that they need. Next slide. So at this point, what we can say is on the side of the Marburg virus disease in Ethiopia, the increased surveillance, increased testing is happening, where especially specifically in Jinka and Awasa in the southern region, with more than 1,500 tests that has been used, 13 confirmed cases, 8 deaths, and 4 recovered with 1 undergoing treatment. Mpox, significant decrease. We have some few countries currently hotspot where we have a strong support to ensure that before we reach to Christmas, we have the curve that is being bended. The ECG has sat, and then we expect to have that feedback by the end of this week, and you will get the clear feedback next week during our press briefing. As cholera is concerned, we learn that it's critical to think out of the box, to do differently from what we have been doing, to rethink the strategy of vaccination, to rethink the wash, and more critically, to increase the type and the size of our partnership to ensure that we have a holistic approach in responding to cholera. So the IMT colleagues, some are in the press briefing here, are in Angola, in Liberia, Kenya, Ghana, and so on, to ensure that the member state receive the support that is required to address those different outbreaks. So with that, I thank you, and I'm happy to take the question for our dear journalist.
Thank you, Prof, as usual, for the very comprehensive updates on all of the different public health emergencies that are happening on the continent and where our colleagues are currently in the field trying to intensify efforts in affected member states as we go into the holiday season. Colleagues, at this juncture, we're going to move into our question and answer section. You already know the means through which you can send your question. You can raise your hand if you would like to be audible on the call. Better still, you can use the Q&A section on the platform and send in your question, and that will be read out to our speaker for today. So let's start off with our question. We go into our first question here. This speaks to the DRC and relative to the security situation. How might the M23 rebels' capture of the Uvra region latest attack or town fought to the DRC affect public health intervention as a new wave of refugees crosses into Burundi? So relating to the recent security situation and the town that was captured, and of course how the movement of people is going to affect public health intervention. So let me add a second one, and then we will allow Prof to respond. The second question say in September this year, the WHO downgraded Mpox, which it had classified as a global health emergency. What is the likelihood of Africa CDC doing the same to downgrade it from the current status as a continental emergency of security concern? So those are the two questions. I think that speaks to the meeting of the ECG, as you mentioned. Over to you, Prof.
Yes, thank you. Thank you so much for the two insightful question. Yes, definitely. The what is happening in eastern part of DRC is what have been mentioned. One, there is no health without peace. We really hope that the agreement that has been signed a few weeks ago and the meeting with the two of head of state will take the time to be operationalized so that the peace can go back in that part. So, nevertheless, with this incident, two things. One, Africa CDC and partners work aligned with the country so that the assessment is being made on the access to the place where we need to support the patient. Two, the support that I mentioned, the collaboration with APURA, who are the military organization to respond to outbreak. It's also an opportunity with that eastern part of DSA to see how we can bring them on board, and then they can support or guide us on how we can work in those environments, still providing the support that is needed. Three, we have other actors that, regardless of those big challenges, can still continue to work. And they're part of the IMST. I'm talking about MSF, Alima, and so on. So tomorrow we'll have our partner meeting, and then we'll hear from them to see how the situation is evolving on that side. Now, on the side of the cross-border coordination and collaboration, yeah, rightly so, you mentioned that there will be the migration of the people moving to Burundi. So once again, our Director General was this week in Burundi. We have a team there, so they will be supporting and working with the MOA to see how to address that new movement of population within their country. So that's what I can say for that. Now, on the side of the Mpox, first of all, in September, WHO lifted the public health emergency of international concern. This is at the global level. WHO Afro maintained the grade 3 for Mpox, which will go
Apologies, colleagues. We've just lost Prof. Yap slightly. Let's give it a minute as he's trying to reconnect. Okay, Prof, we lost you for a minute. You are back. You
Yes,
were
thank you.
responding to the question on the issue of the Mpox declaration with WHO. Over to you.
Okay, so I was saying that the ECG in September have decided to extend the effects. Now they look at the data, they really appreciate once again the 94% decline. So the options are the following. The first one, the lift the facts with some clear recommendation. The second one, they decide to maintain based on the evidence that they have. And the third one will be to decide to postpone the decision for the next 5 or 6 weeks so that they have a better understanding. So we'll get that feedback. But we believe that with all the effort that has been implemented, facts is something exceptional. So at some point, when we realize that the outbreaks will continue to happen, Mpox will become endemic. That's why we have a transition roadmap for countries. Now, it might be the time to instead focus on how we support countries rather than continuing to have this platform. But that is for how our committee to decide, and next week we will advise you.
Thank you, Prof. Let's take two additional questions. We don't see at the moment, we don't see any hand raised. So we continue with the question coming through from the Q&A in the chat box. So this one is from our regular colleague, Kemo Chen from Minor Reporters in Sierra Leone. He is concerned to know where is Sierra Leone as it relates to the countdown on declaring Mpox over, what conditions are expected to be met for the country to declare Mpox over. So that is what Kemo is concerned about. Our next question here. Question number 2, how is the continued civil crisis in Sudan and the DRC affecting Africa CDC community health workers' response in the different outbreaks? Over to you, Prof. Those are the two questions for now.
Okay, thank you. Thank you. So the first question for Kemo, it's an opportunity for us to remember or to remind how we think the public health should be. Africa CDC believe that countries leads, the region coordinates, and the global support, which mean at the level of the country, which is Sierra Leone, they are following the number of days without any case. There are some districts that have not reported any case for the last 136 days. And they are ordered the lowest that are now around 36 days without any case. So they are thinking of reaching the 42 days without any case by the 16th of December, when at the country level, they will be able to declare that they no longer have Mpox, like DRC did a few weeks ago on the 1st of December for Ebola. So those are the criteria. When there is one case, you declare the outbreak. When there is no case, without 2 times the incubation period of 21 days, then you can declare the end of the outbreak. So in that basic, Sierra Leone will be able to declare. But now as a region or as the continent, it's when the different countries will reach a threshold where either there is no case for countries that have never had any case, or when they go back to the endemicity. A country like DRC, we don't expect a time where there will be zero case because they've been having Mpox for a while. But if we go back to where they were before we declare the facts, at that point, we can look at it. Now, one critical point that the ECG mentioned yesterday is yes, we should look at the figure, but let's have in mind that lots of effort has been put in place, especially in the lab decentralization. So the capacity to detect now and to do the surveillance now, it's much far better than where we were when we were declaring the facts, which means that the number of cases that we were seeing at that time, were they the real number of cases? Most likely no. So it's important to look at it, but rather to look at what is the current risk at the continental level, at the global level. It's in that basis that they will decide what is the best way to move forward. Now, at the question on the South Sudan and how the community healthcare workers and the response is affected. Definitely is affected on the side that though we have the healthcare workers who are trained, who are ready, though we support South Sudan Public Health Emergency Operation Center to be ready in terms of infrastructure, in terms of training the staff, in terms of assessment, readiness assessment, all those parts are done. But now, to support, you need to have access to the population. That way, it's critical to work with the peace unit of the African Union, but also to other partners, like I just mentioned, APORA, but also other NGO like MSF, with whom we are really trying to strengthen and to see how we can support and still have access to some of those people. So definitely, we are challenged because of the insecurity, but also in the other hand, we are finding innovative way and innovative partner so that we don't leave anyone behind.
Thank you, Prof. Let's now go to the main platform. We have two hands up. Let's first speak our colleague Rachel Abuja from Nigeria, the news agency of Nigeria. Rachel, you have the floor.
Good afternoon, Prof. and colleague. Thank you for your how will I put it? Thank you for your presentation to say, let me not say much. Prof, I would like to know how the new refugees influx from is it Uvira crisis, shape African CDC public health response? And does this highlight movement of people influence whether Mpox should remain a continental emergency? That's one of my questions. Now, given countries like Sierra Leone are approaching the 42 days threshold for declaring the end of Mpox, while improved surveillance now detects more cases than before, as you said, and insecurity continues to limit access in places like South Sudan, how is African CDC balancing these realities to determine when Mpox can be safely downgraded at the continental level? Thank you and over.
Those are two questions. We'll just go over to Prof for response, then we move on. Over to you, Prof.
Okay, thank you so much for the question, which allowed me to add more clarification on the criteria. So at the continental level, as mentioned, we look at a time where for more than 45 days there is no case. And then we consider that the country are in control phase. This is at the continental level. Now, so far we have 7 countries that are at the end, and Sierra Leone is still to enter in control phase, which will happen on the 16th of December, as mentioned our colleague Kemo Chan. Now, the decision to downgrade has many criteria, actually 5, which include the sustained human-to-human transmission, which also includes the risk at the regional level, at the continental level is still present. And you rightly say that if we have those movement of population, they might be a risk of increasing the number of cases from DRC to Burundi, as an example. But now, the other critical component is the capacity of countries to respond to the outbreaks. At this point of time, is Burundi really able to respond to an Mpox surge? Definitely yes. They've proved it. So what they will need some support, which is currently in country, to ensure that they can also properly address this new influx of migrants. So based on that, we can assess the number of cases might increase, maybe yes, maybe not. If all the surveillance, the detection, the isolation of positive patient in treatment center have they done previously, definitely we are quite confident on the capacity of the country to control. So which means that this will not be the significant factor to not to downgrade the Mpox as the public health emergency of continental security. So, but still on how is shaping Africa CDC and the IMST is also to reemphasize the need to strengthen the cross-border coordination. Together with the World Bank, we are supporting the country in two different things. One is to ensure that the MOU between the country are happening, because now if you want to do the contact tracing of people moving from DSC to Burundi, if there is no agreement between countries, you won't be able to do so. So that's something critical. But also to support those gathering where the different countries, DRC, Burundi, South Sudan, and others can meet and ensure that they have a common process, their harmonized way of implementing the surveillance and the response. This is something critical that definitely those different occurrences are pushing us to actually accelerate. Thank you.
Thank you, Prof. Let's take one question here from our chat before we go back to the hands that are raised. This question says, is from Ines Villa. Villa is a senior healthcare reporter from APM, Market Access. Ines wants to know, what is the vaccine availability outlook for Mpox in 2026? Yes, we are winding down 2025. What does it look like for 2026? That includes procurement, including funding availability, and any progress on tech transfer for Africa. Over to you, Prof.
Thank you. So I have my colleague, Dr. Charles Ibeneme, who is currently in Liberia, who will be happy to answer that question. Over to you, Dr. Charles.
Dr. Charles.
It seems that he has some few connection issue. So what is currently is Gavi, the Global Alliance for Vaccine Initiative. Dr.
A
Charles, can you
moment,
hear
Prof.
us?
You are muted if you're speaking, Dr. Charles. Maybe if you can unmute. Hello, can you hear us, Dr. Charles? Okay. I think the connection is challenged. So, Prof, you can go ahead.
Yes, yes. So what the Gavi, Global Alliance for Vaccine Initiative, has approved is the availability of 500,000 doses with a with a support of $7 per dose that the country that are needed will be able to receive starting for next year. So that is what is
Apologies, Prof. Okay. Sorry, I was trying to speak. The network was cutting off. Can you hear me now?
Yes, we can hear.
Okay, Dr. Charles. Yes, we can hear you. Prof was in speech.
Yeah, thank you so much. And apologies for the delay. So the question around what the outlook is for 2026. Currently, we do have visibility of a 500,000 stockpile that has been approved by Gavi board for 2026. So we believe this could set the pace, in terms of our country availability of vaccines in 2026. However, we are currently still undertaking, through the IMST, of course, a deep dive in terms of trying to understand what the demand from the countries will look like going forward. This would also help shape the entire vaccine availability discussion. And I see there was a question around local manufacturing of vaccines. So all of this is what is being put into context, because for us to also push forward the discussions around local manufacturing of vaccines, we need to have a clear picture of the demand coming from countries. Currently, there is no guidance from SAGE in terms of preventive vaccination. However, we would be working closely with the countries to really understand what the demands look like. Currently, teams are in countries. We were in Ghana, as Prof did mention. Part of the discussion was to know what the demand outlook is, especially for Ghana. And we'll be doing that across all the member states that have been affected by Mpox. And then we'll also be able to now look at both countries that are endemic against countries that are non-endemic, so that we're able to have a very clear picture of the demand forecasting going forward. Thank you, and back to you, Prof.
Yes, just to highlight on that, the opportunity of those outbreaks is to think or rethink the way we are responding. And one way that we've learned from yellow fever and others is the use of fractional dose. So with one dose of vaccine, the capacity to vaccinate 4 to 5 people. And we have countries like Sierra Leone and Uganda that are ready to start. And they will be the first to use the fractional dose for Mpox in the continent. This has been used in UK, in US, but that will be the first in the continent, which means with the evidence that they will generate, instead of having 500,000 doses, we'll be talking about 2.5 million doses, so which can be a game changer on the availability of the vaccine. Now, on the other side, Dr. Charles mentioned the herd immunity. One of the reasons why we have Mpox now is because we've stopped the vaccination once we eliminated smallpox. So at some point, if we really want also to eliminate Mpox, we'll need to have an immunity in endemic countries, which means vaccinating the 5 to 6 million in endemic region and provinces. And this is what is critical in terms of demand to ensure that the tech transfer is happening, moving toward local manufacturing. So just to say that all the pieces are connected and Africa CDC is pushing so that we can reach that local manufacturing agenda.
Thank you, Prof. Thank you, Dr. Charles. Now let's go to our colleagues who have their hands raised. We will recognize our colleague Michael Garissa from the Health Times of Zimbabwe. Michael, the floor is yours.
Okay. Thank you, Prof. So if I heard you correctly, soon you might be declaring an end to the Mpox. But we can see that already we are getting into the festive season, and there's that Mpox clade that is sexually transmitted. How big are the chances of infections arising, along the lines of that sexually transmitted infection, and that jeopardizing you proclaiming that the Mpox has probably come to an end? Thank you.
Prof, we'll allow you to take that question.
Okay, thank you. Thank you so much, Michael. I think this is a very good question. Are we going to say that Mpox has ended? No, that's not what we are going to say. We are going to say, based on the recommendation, whether Mpox is still a public health emergency of continental security, which means we have that strong continental coordination to respond to these outbreaks. Now, going toward that, even if we still have countries that have surge of Mpox, like they do have for other disease, then it will be based on the capacity that we have seen countries. And this capacity is the National Public Health Institute that in Sierra Leone, in Liberia, in DRC, in many countries have been able to properly respond to that outbreak. So even if there are some surge of case, they will have the capacity to do so. That's one. Two, we've worked together with the member state, the IMST, and the partner on a document called the Transition Roadmap. How Mpox will now go from the emergency to the routine. And our country will contextualize this plan to ensure that now they can be able to prevent or to respond depending on the epidemiology to the Mpox. And now, three, just give you an example. COVID-19 has never ended, but it's no longer a public health emergency of international concern, which means that even if the case of COVID are raised, and they might be raising in some place of Europe, US, as we are speaking now, we don't have the same level of alert and of response. Why? Because we know how to deal with that. And this is where we are going with Mpox. Thank you.
Thank you, Prof. As we wrap up the session for today, let me take this question from the chat. As numbers, still on the issue of Mpox, as numbers are going down for Mpox, is there a possibility that testing is also going down, or is this a true effect of control via vaccination and prevention of transmission through better community understanding?
Yeah, thank you. Thank you. That's the very good question to end this briefing on, highlighting that the decline that we see at the continental level has different drivers. And one of the key recommendations that will definitely come out from the ECG is the research to support us on identify what are the key driver of the transmission, but also of the decline, knowing that we won't have the same driver in all countries. It will be country specific. The decline that we've seen in Burundi has happened without vaccination. But definitely, when you go to Uganda, and we had a presentation where they were really showing the successful impact of the vaccination targeted strategies. So just to highlight that there will be different drivers that explain what we are seeing. So the researcher, we have Professor Mosoka, who is currently connected. Maybe Dr. Mosoka, you can say us a word on the different studies, the social behavioral study and so on, and the transmission that will allow us to understand better the driver of the decline and the transmission of Mpox in the continent. Dr. Mosoka?
Thank you so much, Professor Yap. As we are generating data to look at the transmission dynamics, we've been able to generate enough data to ask key questions, like what are the household factors, the age distribution as it comes to the clade. The correction we want to make is that we really don't like to say sexually transmitted and Mpox. We think it's sexually associated because of the close contact. And so in the coming days or weeks, we'll be able to share those issues and also look at disease progression with respect to a clade that we are not tracking hospitalized cases and understanding exactly how the disease progression is impacted by a specific clade. We know that the clade is geographically dispersed, with Central Africa mostly having the clade 2B, the clade 1B, but then we see co-circulation in the DRC, West Africa having the clade 2B. We're trying to ask this key question, looking at sequence data and see how it influence sexual transmission, also household behavior. That also the fact that we have seen a huge data from 18,000 interviews we conducted across the continent to see that behavior is a major issue. While people have a generalized knowledge about Mpox and prevention, the knowledge is still superficial. So there's a lot of work needs to be done to promote interpersonal communication so that people can have an in-depth knowledge. There is still stigma. There is big stigma for those who get Mpox, and people know what to do, but we don't see the perception for vaccine at the level that we want. So there's more work to build awareness. We see an average around 78 to 82%, depending on the country. So we need to work more intensifying knowledge for isolation, and we have in the coming weeks to explain internal dynamics and the cliff factors that are responsible for the spread, including sexual transmission. Thank you, Professor Yap.
Thank you, Masoka.
Thank you, Prof. Thank you, Dr. Fowler, for the insight on the studies that's been done. With that, colleagues, that brings us to the end of the press briefing for today. I see a question that comes in the chat asking if we're going to have a briefing on Christmas Day, when are we resuming in January. We assure you that we still have one more briefing section, hopefully next week. We're going to be here next week. And during that next week briefing, you're going to be informed as to what will be happening over the holiday break. So just hold your peace. Join us next week for another fresh update as it relates to health emergency on the continent. With that, I'll turn over to Prof for his parting comments as we close the session. Over to you, Prof.
Yes, thank you. And thank you for the question. So next week, we'll have our Director General, Dr. Jean Kaseya himself, who will be attending the last press briefing of the year, most likely. And he will give you feedback because last week we were asking quite a number of questions on the engagement with the US government. And today there was a meeting with the 13 out of 16 Ministry of Health that are going into that bilateral discussion with the US government. So we'll have a feedback next week, but definitely we know that the position of Africa CDC on supporting is to ensure that the country has ownership, leadership, and sovereignty, but also that those agreements work around a national plan so that country don't have fragmented plan, but just one that can be the basis of the discussion. And also critical to ensure that the fund will go directly to the government, which is definitely the angle that the US government is taking. And of course, reinforcing the critical need of pool procurement mechanism. So next week, you will have more insight of what did happen and and the way forward. It's also an opportunity once again, and actually every Thursday, to thank you as the journalist, but also to all the colleagues who are currently fighting against Mpox, cholera, measles, Rift Valley fever, and many others on the side of the epidemiology, the case management, the RCC, the research, and all together. So I really want to thank you on behalf of Africa CDC for the great work that is being done in the field to support our member state. So with that, I wish you all a very good day, a very good afternoon, and a very good evening, depending on wherever you are. Thank you.